my mode of practice is strictly treating eye disease, and it's a surgical-based practice. So I come from this at a little bit different. This is all I've ever known for 25 years is treating ocular disease. So we're gonna do this in a very, very, very clinical fashion, y'all. And iritis is the same in the U.S. as it is in the U.K. You know, it's cell and flare in the anterior chamber. This is the terminology. And in school, is there a difference between an iritis and a uveitis and an iridocyclitis? That was always a big question. And you know, the fact of the matter is, pathologically not. It's all inflammation of the uveal tract. But really, clinically, I think there is a difference. When I write uveitis or type now in uveitis in my chart, to me that signals a difference than iritis. Iritis to me is a regular old iritis, has some cell, maybe some flare, it's going to get better. When I type in uveitis, and in the States we even have a different code for that, a different diagnostic code, it signals a bigger problem. So how can we talk for an hour on iritis? It's because they're not all the same. You know, half of them just happen. And as a student, you know, you'd say, well, what caused this? And sometimes, about half the time, it just, you know, Schmidt happens, right? Sometimes it just happens. It's and then about 20% of those are traumatic. We should, you know, those are pretty easy. I was at a pub last night. Manchester Man U lost in the match, and I got in a fight. I got hit in the face. I have an iritis. That's a pretty simple path, right, to follow. The challenge comes in the 25% that have some type of underlying cause, and that's where one of the real challenges with this disease is trying to figure out which ones aren't the regular old iritis, which ones might have a systemic etiology, and to try to find, you know, what's causing them. But I want you to understand this. Number one, about half the time it just happens. People are allowed one of these in their life. In my experience. Also remember, y'all, it's an inflammation. It's not an infection. If you type in the term uveitis or iritis, they do not need an antibiotic. So the treatment's pretty simple. It's inflammatory, so you give them steroids. It's pretty simple. But we're going to talk about the different levels of treatment and some of the we'll start with simple and go to non-simple over the next 45 minutes. How about that? And I say this all the time to my students. I say it all the time to my referring doctors. With any condition at all, you have to have a goal of treatment. What are you trying to achieve? It's one thing to make a diagnosis, and oftentimes it's harder to make the diagnosis than it is to decide what treatment to embark upon. But you have to know what you're trying to achieve. And so for uveitis, the goals are pretty simple. When a patient comes into your office with a uveitis or an iritis, their eye hurts. They're not there because I think I have 2+ cell in my eye. They say my eye is sore. So one thing we can do is make people feel better, and that's the goal in my mind for goal of treatment is let's make them feel better first. Let's make them feel more comfortable. If their visual acuity is depressed, let's get them seeing better. Now, the fact of the matter is with the uveitis, to achieve those first two things, you would do it with number 3. You want to decrease the inflammation. But I don't walk into an exam room and thinking my first thing, I'm going to decrease inflammation. No, my first thought is let's make the patient feel better and keep the patient seeing. Just so happens in uveitis, the pathway to do that is by decreasing the inflammation. Okay? So y'all have a goal of, no, I don't care what it is. They come in and they broke their glasses, they need new glasses. The goal of treatment is to get them seeing better, correct their myopia, right? It's a goal of treatment. And I think if you take that idea into every exam room, it's going to help you. What can I do to make this patient achieve their goal? You know, what can I do to make this patient better? It's only after you do those first 3 then that I sit back and say, it's a uveitis. Is there a reason for it? Do I need to ferret out a reason, or is this one of those that just falls into the regular old iritis category? So I don't go and think, this patient has sarcoidosis. right away. I don't. I diagnose it as uveitis. And then I take a step backwards and figure out maybe whether or not this person needs some other blood work. And then number 5, and this is something that you always want to keep in mind, but I don't ever want it to be, especially for those of you that are on this pathway to getting your, I don't know what it's called, but the therapeutic certification, I guess. In the States, when I was coming up, y'all don't know what that means. So when I was a tadpole in the profession, it was always, use steroids. People can go blind for steroids. We can kill people with steroids. Fact of the matter is, y'all, you can't. All right, number 1. And we are also when you're a tadpole in the profession, you're told that side effects are just paramount. You have to understand side effects. You do, but don't let them scare you. We're dealing with steroids, which are great anti-inflammatory fighters, and they have some certain inherent side effects, but you can't be scared of the side effects. You have to be aware of the side effects. And if the side effects occur, you have to react to the side effects. But I would implore you to not let the side effects scare you away from treatment. Because sometimes, again, I said this once, I'll say this, sometimes, y'all, Schmidt happens. Sometimes side effects occur. If you treat enough eye disease, you're going to have side effects. It's your ability to react to that and be aware of that makes you a good doctor. Okay, so that's that. Now these are some not quite rhetorical questions, but I want you to think about this through the course of this talk. Okay, the bottom line is the first bullet point: are non-steroidals effective in this? They just don't work well. They affect inflammation at a different level, down the inflammatory pathway a little bit. So steroids are much more effective at treating uveitis. Now, the only reason that people would use non-steroidals in this is if they had a proven side effect from a steroid that made the patient really unable to use a steroid. That's rare, y'all. Okay, it's super rare. So the other ones we're going to talk more about under the cloak of cases. I'm going to walk through 3 cases with y'all. The answers are uveitis and steroids. All right. Those are the answers. And again, feel free to talk amongst yourselves, as you would say, okay, if you need to. By the way, there is a difference between a granulomatous and a non-granulomatous, both pathologically and treatment-wise, and we're going to talk about that. There's a difference between acute and chronic. There's a difference between recurrence versus recalcitrant. Recalcitrant means it probably never got better. It maybe waned, but it never got gone. Right? Recurrent means it got gone and then it came back some period of time later. So there's a difference. The reason I put this slide up, y'all, these are my guiding principles to how I treat the uveitis. Again, the answer is uveitis and steroids. But how I use steroids is different based on all this stuff that on the slide. So here's a regular iritis. 40-year-old gentleman comes in. He's a Hispanic male. Complained of a sore right eye for 3 days. And y'all, that's how they're going to come in. They're not going to come in holding their head in their hand, in acute pain. It's an ache. It's a pain. But it's one that gets them to get off their chair and go see a doctor for. Okay? That's what they're there for. They have a sore eye. So no discharge, and he wasn't complaining of redness. He was complaining of a sore eye for 3 days. And it may be a little worse than it was on Monday, but now it's Thursday, and it's bad enough that he got up off his chair and saw a doctor. 20/25 vision in that eye, 20/20 in the left eye. So, one question I would ask, again, fairly rhetorically, is his vision depressed? I've never seen the guy. I always go under the assumption that everybody should see 20/20 until proven otherwise. So I would say, maybe his vision is a little bit depressed, maybe not. I don't know. But he's 20/25. Pressure is good. Now, this is a very light room. Can you all see that okay? All right. Don't you find it super helpful when they have arrows in their eye? Yeah. What could be the problem here? Those arrows are superimposed by me. All right. I'm pointing to a phenomenon that's really, in my mind, classic of a uveitis or an iritis. See the lack of redness there? You know, it's not a conjunctivitis type of redness. It's a bit red, but it's not a rip-roaring, it's not a rip-roaring rednness. But what those arrows are pointing to are, ciliary flush, circumlimbal injection. So I have my pointer over here, but as the vessels, they get engorged in that circumlimbal area there. That's where the inflammation is. It's at the ciliary body. Y'all, when you see that type of red, and I don't, can y'all appreciate that, or is it too bright in here? It's okay, right? So when you see that without the arrows, but that injection circumlimbally like that, it's classic of uveitis. Your next move should be to go into the anterior chamber and look for cell when you see that. Very few other things will give you ciliary flush like that. Circumlimbal injection, whatever you want to call it. Okay, so clue number one. And I also, again, want to point out the relative lack of redness there. Right? Again, it's not this infectious-looking type of eye. So there's the anterior chamber. Now, how do you know you're in the anterior chamber? Good question, right? And the only way I can tell you that you're sure, so you focus on the cornea, and then you focus on the iris, and then you defocus, you pull back until neither the iris nor the cornea are in focus. So they're essentially both equally defocused, right? Then you're sitting in this optically empty space. That's the only way I can tell you how you know you're in the anterior chamber. And I'll give you another couple hints here, y'all. When I was a resident, we were told to make a tiny little slit beam and find the anterior chamber with a tiny little slit beam. What I'll tell you is that's stupid. If I want to find an optically empty chamber, I'm going to bathe it with light. And then I want to be able to find these cells that are floating around in there, right? So I would tell you to make it a big beam, as bright as you can on the rheostat. Turn it up as bright as you can. Focus on the cornea, focus on the iris, and then defocus, and you're in the anterior chamber. And then you sit there, y'all. You sit and you wait for the cells to come up. And they come up from the bottom to the top. There's a current in the eye. And if you sit there, sometimes you'll see this. Now, this person has grade 1 cell. This is not grade 1 cell. Grade 1 cell is supremely hard to photograph. And so one of my daughters, enhanced this, and she went overboard, and she'll be reprimanded for her overexuberance on this one. But this is not grade 1 cell. If this person actually had this, it would be more like 2+ or 3+. But the illustration is there to show you what cells look like. That's what cells look like. And the other thing I want to show you is that's all there is in this one is cells. There's no, see, it's a black chamber. It's still an optically empty chamber except for the presence of these cells. So there's no flare. I'll show you pictures of flare in a moment. So y'all, this is a regular old iritis. Ciliary flush, soreness in the eye, cells. Regular old iritis, okay? This is what 50% of the people that get iritis are going to have this presentation. So, and again, this is the common presentation. Also remember the pupil, we were taught the pupil is diagnostic in uveitis. Y'all, it is not. The pupil doesn't read the textbook. It doesn't know what it's supposed to do. Sometimes the pupil in uveitis might be miotic if there's a lot of inflammation. Sometimes it might be dilated if there's synechia. Most of the time, you know what the pupil does? Acts normal. In a grade 1 or 2, a mild or moderate uveitis like this one, pupil's going to be fine. So the pupil's not diagnostic, but I would make a note of it. Because if it's miotic, you want to get it not miotic. If it's dilated, you want to get it not dilated. You want to keep it normal, okay? Again, this is the common presentation. So the question I have for you is, how would you treat it? The answer is steroid, right? So in the United States, we would use prednisolone acetate. Pred Forte is our go-to drug for this one. That's an easy solution, right? But in the States, I'll tell you, we undertreat this. So if I was, in fact, I just gave this lecture in New Jersey. London wins, by the way. New Jersey, London, yeah. The answer would be, how often would you use a steroid? The answer in New Jersey was 4 times a day. And I'll tell you, it's not enough. That's the minimum basic need of an iritis patient is 4 times a day. When they come in with a uveitis, and this is easy. This one's easy. There's nothing else. There's nothing complicated about this one. It's cell, maybe a little flare, but not really, and redness and soreness. Put them on a steroid. This person should get better, but you need to put them on a high dose of steroids. My minimum is 6 times a day for something like this. And for some reason in the U.S., optometrists would go 4 times a day. That's a lot, and it's really not a lot, y'all. So one of the mantras I'll tell you is if you have a uveitis, really treat it. Get them on, get them off as quick as you can. That's the way you minimize side effects. Side effects are dose dependent, so the longer you keep them on a steroid, the greater the chance of them having a steroid response. So treatment point number 1, get them on, get it off of the steroid. So I would do 6 times a day at a minimum. Now I have a question for you. See, the number 1 is atropine, a red top drop. Would you need a red top drop for this? Would you want to dye? Would you want to make the pupil midriatic? Again, I see a no, I see a absolutely, and those are the right answers. You're correct, all 3 of you. Understand this: the reason you would use a red top drop, if you want to, personally, I wouldn't for this one, but the reason to use a red top drop is because it will help prevent synechia or break synechia. This person's not at any risk for synechia. Those cells I showed you, they're not sticky, they're just kind of there. They're inflammation. So this person is not at any great risk for getting synechia. But the other reason to use a red top drop is it makes the patient more comfortable. They feel better. It breaks the ciliary spasm. So if you do it in this case, you're doing it just to make them feel better. So it certainly wouldn't hurt to put one in at the office. You'd want to dilate them to look at the optic nerve head anyways. But perhaps you don't have to prescribe it. Just apply it in the office. And if you prescribe it, you would do something twice a day, probably for a few days. Now here's a big question. When would you see the patient back? That's a big question. And the answer to this question is all dependent upon what day you first saw them, right? If you saw them on a Thursday, like I don't work Fridays or Saturdays, so that's an easy one. I'll see them Monday, right? My point is, this is not a weekend wrecker, right? You don't need to come in on Saturday or Sunday to see this person as a follow-up. My other point is you want to give the steroids a chance to work. I don't know if y'all have this phenomenon. In the United States, we have this phenomenon. We send a prescription over to a pharmacy. Send prednisolone acetate to use 6 times a day at the pharmacy, and it's a Tuesday. Most people in the States will pick it up, at least in the southern United States, about Thursday or Friday. They'll roll in to pick that up. They get around to it a few days later. So if I see this patient on a Tuesday and I see them back Thursday, what do I expect to see? Exactly the same picture. Even if they got the drop on Tuesday, you've got to give the steroid a chance to work, right? So, see them back 3 to 4 days later is what I would tell you. Maybe 5. If it's a Wednesday, maybe you see them on a Monday, right? It is not a weekend wrecker. But I also wouldn't put it out a week, If you saw them on a Monday, I would maybe see them on a Friday. A week's probably too long, but 2 days is too short, clinically. You dig? We got that? That's a very important question. So patient comes back 3 to 4 days later, decreasing cells, no photophobia or pain. So the pain's better. The reason he came in was his eye was sore. He feels better. Great. We've accomplished what we want to accomplish, right? Pressure's still good, not having a steroid response from the 6 times a day that the patient's on the drop. Vision's 20/20 now. Vision's back. The reason his vision was decreased probably is because it was a little bit of a ciliary spasm there, and he just wasn't focusing as well. Now, it's decreasing cells. Cells are not completely eliminated yet, but they're better. So now the question comes, can we start to taper the steroid? Because you have to taper steroids, y'all. If you're using prednisolone acetate or dexamethasone, the prednisone-based drugs, you need to taper. I don't care what you might hear differently, but you need to taper. Can you start tapering even though there's still cells in there? And I'm not going to answer that equivocally. I do. Now, there's some other smart people that will say, I never taper until the cells are gone. We've made a nice achievement. We've achieved everything we want to achieve, except we've not eliminated the cells. They're on 6 times a day. They're doing well. I kind of reward them. I say, you're doing great. Super duper. You're using those drops just like we want you to do. Tell you what, use them 4 times a day. Because I promise you, 4 times a day is way more easy than... 4 times a day is it's way easier, right? That's what y'all would say. We'd say more easier, but it's not correct. And I caught myself, and then I still said it. 4 times a day is easier to use than 6 times a day. And so it's a little bit of reward for the patient. This way I look at it. Let's go down to 4 times a day, and I'll see them in about a week. Right? Because they're better. We know we've got this under control now. And at 4 times a day, it's probably not going to flare back up. But now I want to obliterate the cells. And so I'll say 4 times a day for about a week. They'll come back, the cell will be completely gone, and then I start the taper. And I do a very quick taper. Once the cells are gone, I would keep them 4 times a day till the cells are completely gone. And once they're gone, then my taper is 3 times a day for 3 days, 2 times a day for 2 days, 1 time a day for 1 day, and they're done. But I'd also recommend seeing them one more time. Once they're done with the steroids, I recommend seeing them one more time because I want to make sure we've got it gone, that we've eliminated it. All right? I feel like we're bridging a language gap here. This is fantastic. Y'all understand what I'm saying? Okay? So keep them on a fairly high dose till you get a decrease. Once you start decreasing it, I would go to 4 times a day, but then keep them at 4 times till it's all gone. Then you can get them off rather quickly. Some people will say, I want to keep them on 3 times a day for 5 days, 2 times a day for 5 days, 1 time a day for 5 days, and that's fine too, y'all. There's no recipe for this. You've got to go by feel how the patients are responding. But this one, he responded really well. I would get this person off real quickly. Okay, let's move on to another one. So here's a different case. Again, the answer is uveitis and steroids. All right, but it's a totally different case. 27-year-old African-American female. Now, y'all, iritis don't generally just happen to young people. 40 to 70-year-olds, although that's still rather young, are allowed to get these more likely than a 20-year-old is. Okay, so clue number 1, she's real young. She's had a sore left eye for a week and mild photophobia. She says she's had a similar quote. Those are her words. I've had this similar infection 3 other times this year. We're now in September. So that's kind of you say, wait, so you've had the exact same thing happen 3 other times this year? Yes, sir. You mean so one time it had mucus and no, it's been like this every time. Did you get treatment for it? No, it went away. That's a head scratcher, right? That's not right. So it's a totally different case than the first one already. So that's not right. That's not a regular old iritis. So that's clue number 1. Her vision's decreased 20/40. And when I see depressed vision like this, the question that I always ask is why? Why is it 20/40? I should be able to answer that after I examine the patient. And if I can't, both the patient and I are in trouble. She has recurrent colds and flu-like symptoms. By the way, she was recently diagnosed 2 weeks ago with asthma. All right? She takes Tylenol because she feels like crap. She's got flu-like symptoms, and she's had those for weeks now. Pressure's good. Here's her. Now, that's a horrible picture, right? A student must have taken that one. But I'm going to show you a couple things. Look at the redness again, or lack thereof. It's not a red, it's not an infectious type of eye. This is why this is why that picture's blurry. Wait, hold on a second. Yeah, so that's a blurry, just not well. Now it looks better here, but that's why it's blurry. So clinically, what do we call those? Yeah, KPs, yeah. I was waiting for someone to, so sometimes, in the U.S. anyways, people would say mutton fat KPs. Now, I've never seen mutton fat in my life. I don't know. Have y'all seen mutton fat? Yeah? Is that what it looks like? I have no idea. I've never seen mutton fat. And I'm from the South, y'all. Apparently, mutton fat is greasy, because those are greasy. If you were to be able to scrape the back of the cornea, it would have greasy feeling to it. So these are KPs. Now, that's a lot of KPs, y'all. It's so much that I can't get a good view through the cornea with this photograph. Can this level of KPs, is it bad enough to cause 20/40 vision? Yeah, I mean, imagine looking through those at the world. It's, our view in is kind of equal to their view out. And that's a lot of opacity. That's a lot of mutton fat, y'all. So, did I answer the question? That's why she's 20/40. I would buy that. I would say, yeah, that's a 20/40 cornea, basically. So, let me show you the anterior chamber. This is not artificially enhanced. This is real life, y'all. So, the first one I showed, we put a lot of cells on that first one, but remember the very first case, the anterior chamber was black, with the exception of those dots floating around. Here, the anterior chamber is not black. That's flare. That looks like a blizzard almost, or a fog bank back there. It's black underneath and above because that's where the beam stops, right? But where I have illuminated the anterior chamber, I didn't say where I've put light in there, right? Illuminated. It's white. That's flare. And also, look at the amount of cell in there, y'all. I don't know if you were taught here in the UK that 0 to 10 cell is grade 1 and 10 to 22. How could you count that? And how do you know you haven't counted the same cell twice? They're moving. I don't count, y'all. That's a bunch, Then there's a whole heck of a lot, which is more than that. But when you have this is grade 4. You can't pack any more cell into the anterior chamber than that. So I don't count, and I would, because it's hard and it's stupid, and you just don't need to, right? It just, clinically, it doesn't matter. They've either got a few, more than a few, or a bunch. So this is a rip roar in uveitis. Also look on the lens capsule, y'all. On the right side of the slide, that's the lens. You can see the schmutz on the lens capsule also. So that just connotates this is sticky. And the stuff that she has in her eye is sticky. It's sticking to the cornea. It's sticking to the lens capsule. But the answer is uveitis. So I'm going to ask you this. Clinically, is this a more difficult case than the first one? And the answer is absolutely. Right? First of all, the way she presents is she's got a lot more going on, number one. She's got much more inflammation than the first person. Secondly, remember what she told us? She said it 3 other times in a year. That ain't right. That's just, people aren't allowed that. You're allowed the first case. You're allowed one of those. You're not allowed this. It's in the rules. It says. So the question is, does this person, she has a uveitis, we're going to put her on steroids. Perhaps is there a systemic etiology? Is there something that's causing this? The first case, the answer is no. How do we know that? Well, that's just a normal plain old uveitis. This one, when you have granulomas, y'all, which are KPs, the likelihood that there's a systemic involvement goes way up. Number one. Secondly, she's basically telling you I've got a problem. I've had this 3 other times. This is my 4th time in 9 months. Really? Again, that ain't right. It's not supposed to happen that way. So she's basically telling you I've got a systemic problem here without saying it. Okay. What is her most, I put this in because I want to try to show you how important it is to be educated, right? What is your most appropriate diagnosis on this one? Yeah. It's granulomatous. We know that, right? KPs are granulomas. So if you see even one KP, you've got a granulomatous case. 2, is it recurrent? If we are to believe her. Now, someone might say, well, how do you know it's not recalcitrant? How do you know it never really got gone? You know, it might have waxed and waned, but never totally got gone. I don't know that. I'm believing what she tells me. I had it once, it went away. I got it again, it went away. I got it again, it went away. That's a recurrence. How many episodes do you have to have for a recurrence? Yeah. It doesn't matter if it's 2 or 10, it's still recurrent. Right? Now I would tell you this, y'all. If I utter the words recurrent granulomatous uveitis in my head, to me me and the patient are in for a protracted treatment. She's had this now for 9 months or so, basically. She's got granulomas, her vision's 20/40. This is a much more difficult case. But this is not one that you refer out, y'all. You can treat this. If you were able to treat the first one, you can treat the second one. Use a steroid and a red top drop. You just use it in a higher concentration, right? So if the first case we used 6 times a day prednisone acetate, how are you going to prescribe the same drop for this patient? More, right? If the first case was 6 times a day, this is every 2 hours or every 1 hour. Sometimes in the States what we do is give it to them every 30 minutes for the first day and then go to every hour after that. I usually don't do that. You know, I get to them every hour thinking that they'll probably remember every other hour to put it in, you know, but they need to use it a lot. The second question I have for you is, do we need a red top drop for this person? And I would say yes. Unequivocally, yes. Patient doesn't have synechia yet, although this was her. She did get synechia. Stickiness invokes synechia, right? That's why the iris sticks to the lens capsule, because it's sticky too. So if you see granulomas, and you saw on that first slide I showed you, there was stuff on the lens capsule already, those patients are the ones that are at risk for developing synechia. Because it's a sticky thing, so it sticks somewhere. It can. So to prevent that, that's why you'd use a red top drop for a person like this. And when I prescribe a red top drop, I don't give them an atropine type of deal, because atropine dilates them, really dilates them. So if they can get sticky down here, they can get sticky up here. And that's worse, because that sets up angle closure type of glaucoma. So I want the iris to move throughout the day. And so I'll give a short-acting red top drop, like cyclopentolate, for instance, or homatropine, because I don't want to dilate. I don't want to incapacitate the iris. I want to keep it gently moving throughout the day, because that's how you prevent synechia. All right. So, you know, again, these are things you can also see with a complicated uveitis. Look at the pressure. Again, sometimes in a uveitis, the pressure's normal. Sometimes the pressure's low in a uveitis because the ciliary body's so inflamed that just the aqueous humor production is depressed a bit. Sometimes in a uveitis, you know what happens? The pressure goes up because of synechia. And all that stuff, by the way, all that stuff that's in the anterior chamber has to go somewhere. Where does it go? Falls into the anterior chamber angle. And if you get enough debris in the angle, it clogs up the angle and the pressure can go up. So again, pressure is not diagnostic of this condition, but you have to pay attention to it. If it's low, it's because there's so much inflammation, the aqueous humor is basically not being produced. If it's high, it's probably because the anterior chamber is being clogged up. All right? Do you think this person might have a systemic etiology? Yeah. Again, she's telling you that. She's got granulomas, number one. She's got a recurrence, and she's 27 years old, y'all. She screams of having a systemic involvement. But again, I didn't walk in thinking she's got sarcoid. Walked in thinking she's got an eye problem, diagnosed it as a granulomatous uveitis, and only at that point do I take a step back and say, now what could be causing this? This is not a regular old iritis. So in my world, these are the 15 things that I think cause uveitises. Now with her, so when I was a resident, I would write blood tests and x-rays to try to eliminate all 15 of these. The reality of the situation, especially in the U.S., is the insurers won't pay for it unless you've got a reason. So this patient's 27 years old with a granulomatous uveitis. I'll tell you, she doesn't have some of this stuff. Does she have rheumatoid arthritis? She has not complained of it. Ask her, ask her. No, I don't have any of that. So we can rule out rheumatoid uveitis. We can rule out Reiter syndrome. We can rule out juvenile rheumatoid arthritis. So we just throw some of those out. But what might she have? What is she likely to have? What's that? Sarcoidosis for sure. TB for sure. Remember her symptoms? She's recently diagnosed with asthma. In the U.S., in the southern U.S., Lyme's disease is I don't know if they have Lyme's disease in the U.K. or not, but Lyme's disease is a big one. What about syphilis? Yeah, I ain't telling her, but she can get it, right? If she does, I'm not telling her, but I got to look for it, I would say those are the 4 big ones in this case for a younger person: Lyme's disease, sarcoid, TB, syphilis. And just as a course of matter, I would always order a CBC just to see. So these are when I think blood tests should be ordered, lab tests for uveitis. Both eyes, that's not right. Basically, if it differs from the first case, even not as dramatic as this, I would order blood tests. Recurrences, recalcitrant, atypical age group, young like this. Hyperacute cases are where the vision's depressed. I would consider a blood work. But certainly recurrences and granulomas, y'all, are those just don't happen. So this is something you might want to keep in your little white jacket or on your computer, your laptop or something. If I think they have syphilis, I would order certain disease. If I think they have Lyme's disease, I would order certain disease. So these are the specific blood tests for the specific things we're ruling out. So for this patient, ordered a PPD because we thought maybe she had tuberculosis. We ordered a SED rate, which is a little high. A SED rate for this is not going to be an 85. It's not going to be 100 or 85 like a giant cell arteritis. It's going to be a little elevated because she's got inflammation, but it's not going to be, in the 70s or 80s. It's a little elevated. Ordered angiotensin converting enzyme for sarcoid. It was negative. Rheumatoid factor negative. CBC mostly normal. Lyme's normal. The RPR was for syphilis, normal. ANA for lupus, normal. So what does she have? Positive PPD. Tuberculosis, yeah, exactly. That's where she doesn't have asthma. She's got tuberculosis. Okay? So, by the way, in a granulomatous, bilateral, recurrent, or chronic inflammation, 64% of the time there's an engine that drives that. There's a systemic etiology. So if you have any of those 4 things, think systemic etiology. They may not have it, but you've got to think it, and you've got to rule it out. All righty? So with her, again, I'm going to fast forward for her because she had a recurrent granulomatous uveitis. Every hour she did pretty good. Started tapering her back to every 2 hours, 6 times a day. She continued to get better and better and better, but she never really got gone. The cells never really got gone. So with her, we had to go to a higher source. Every time I got her down to twice a day, it came back. So she's someone that needs a better delivery system of steroids. The drop's not enough. So for something like that, you would do orals or injections. I did a sub-T-nonce injection of a steroid on her, and she did okay. She's still on a steroid. But sometimes the drops don't get it, right? So if they continue to flare back up, you need to go. Then it's telling you the drops aren't enough. I need either something systemic or injected into them. All right. Now let's move on to the next one. So 51-year-old lady. In your intake forms, what are you here for? She told me what was wrong with her. She said, Iritis. Eyeritis. Public school in the South, y'all. And she was right. She had an iritis. I'll show you. She was absolutely right. She was treated for this for a year, by the way. Never completely resolved. When she came into my office, she was using Predforte 4 times a day in one eye, atropine twice a day in both eyes. And she'd been using that combination for a year, more or less. And she still wasn't better, y'all. Arthritis, chronic cough, high blood pressure. Throbbing, intermittent pain, radius or temples, chronic redness in her left eye. Let me remind you, she's on a steroid 4 times a day. Yet she still has symptoms. She's still red. Photophobia. You think? Atropine twice a day. Poor near vision. So I didn't know what was wrong with this lady, but I can tell you what I told her without looking at her. I walked up to her and I said, she had a great Southern name, by the way. I said, Ms. Rosetta, I don't know what's wrong with you, but I promise you in a week you're going to be able to read. And she said, Jesus, thank you. And the student's writing it down. He promised her she could read. Well, take her off the stupid red top drop, right? It's obviously not doing her a lick of good, and she's dilated, you know. You'll be less sensitive to sun. I got my eyes closed. I'm like a televangelist at this point, you know. I promise you, you're going to be less sensitive to sunlight. You will be able to read in a week, Ms. Rosetta. Oh, dear God, thank you, thank you, thank you. I knew he led you to me, or he led me to you, right? Yeah. So I told her. Here's who she is. She's 20/50. She's got 8 millimeters fixed pupils. Again, not because of an aneurysm, because of the red top drops. No pain on movement. Normal slit lamp exam in the right eye. Now remember, she's on steroid in one eye, red top drops in both eyes. One eye is completely normal. Left eye, in the presence of steroids, still has ciliary flush, 2+ cell, 1+ flare. Weird, huh? Steroids are supposed to take care of that. By the way, she's got a PSC. You think? Steroid for a year. She's 20/50. So now you take a step back and say, all right, what the heck? Right? It's a uveitis. But is it the same as the first case? And that's the point I'm trying to make. The answer is uveitis, the answer is steroids. But it's totally different, right? She's been on Predforte for 4 times a day for a year. She's not better. So you've got 2 choices. Either up the dosage of you have 3 choices. Up the dosage of the same drop. Go to a stronger drop. Do y'all have Durezol here? Difluprednate? We have a drop called Durezol, which is a stronger steroid than Predforte. It's about twice as strong. Which is what I would do for this person. If 4 times a day regular steroid didn't work, I'm going to go at least 4 times a day super steroid. Or the other choice is let's put her on something oral, oral steroids for her. But she needs something stronger at a high dosage, for sure. And do you think perhaps there's a reason that she can't get past the uveitis? This is another one that screams of a systemic involvement, because on a steroid, all 4 times a day, she still has 2+ cell and flare. 5 minutes, I'm not stopping. You can't. What are you going to do? So again, I'm not going to show you the pictures, except you see what these are on the iris? Busacca's nodules, Kepi's nodules. If they're by the pupil margin, they're Kepi's nodules. These are Busacca's nodules. Granulomas, y'all. She doesn't have KPs, but she's got a Busacca's nodule, which again is a granulomatous uveitis, a granuloma. Alrighty? So who cares what her most appropriate diagnosis is? She's got chronic uveitis, basically, or recalcitrant is probably the better word. It's not getting better. So you've got to go to a higher source. You've got to use a stronger steroid more often for this case. So I would use Durezol probably every 4 hours or every 2 hours. Durezol's stronger than Predforte. I don't know if y'all have an equivalently stronger drug in the UK that you can use instead of prednisolone acetate. If you don't, you'd have to go to prednisolone acetate every hour for something like this. You've got to get it gone. Now here's the problem, y'all. What about the atropine? What did I tell her? I got to stop on the atropine, whether she needs it or not. I got to get her reading in a week. I told her. I promised her that. So I'm getting her off the atropine, right? Y'all, she has enough atropine in that brown eye. You could squeeze her iris and fill a 5 ml bottle of atropine. She's got enough to last her for a couple months in there. All right. Again, in the essence of time, what do you think she might have systemically? Those are the tests you would order. Sarcoid, I would say, right? African-American female with she's got a chronic cough. Can she have TB? Yeah, but why would I put 2 TB cases in a row? That's stupid. Could she have syphilis? Again, I'm not telling her, but she might, right? Same thing, Lyme's disease. You think the same thing, but she says she's got rheumatoid arthritis, so I would order for rheumatoid factor. I would look maybe do a Sjogren's test on someone like this. So these are the tests I would order for her. 1 week later, she feels much better. She's reading better. By the way, she's on Durezol every 2 hours. Trace cell, no flare. Gee, how about that? Y'all, sometimes prednisolone acetate isn't all that. You know? Sometimes you have to go to a higher source. So she's getting a lot better in a week, but look what happened, y'all. Her pressure went up to 31. So this is great. This is a great cross section of, and this is just like in the U.S. too. I would say pressure went up to 31, and 2 people would go, "Oh my goodness," and then some cat, see, you did it again. She's like, "Ain't nothing but a thing, you know, no big deal, right? Big deal, big stinking deal, 31." Table over here says 31. Is it a big deal or is it not? The important point is you realize that pressure went up. Why did her pressure go up? Because we went to a stronger steroid at a higher dose. It's dose dependent, y'all. So, I've got a minute. I know this. Don't show me that sign. I'm very sensitive. And they want me to take questions, but I'm super fragile, so don't criticize me. You can ask questions, but do not criticize me. So she's getting better on every 2 hours on a strong steroid. So that's great. You want to keep that pressure up. You want to keep her on that steroid for a period of time. You have to. But what about the pressure, y'all? Do you treat that or do you not treat that? Now, doctor over there is like, no way. 31? Forget it. That's nothing. 31? Oh my goodness. We have to treat, right? Definitely. What if I said her cup-to-dish ratio is 0.8 by 0.8? Do you change your mind? Yes. That's why God created a direct ophthalmoscope, y'all. Better yet, God created a 78 diopter lens to look. What if it was 0.2 by 0.2? I might be more like you then. I might be cavalier and say 0.2 by 0.2, 31, she's not in any danger of getting anything. You know what happens though, in the right eye, she's also 0.8 by 0.8. She's probably got glaucoma, y'all. So a 0.8 by 0.8 cup-to-disc ratio, I would treat for 31. A 0.2 by 0.2, I might leave it alone. So I have one other question for y'all, and then did you want to take questions, or are we done? Okay, one other question I have for you. How are you going to treat a pressure 31 in this patient that has an inflammatory condition? You're going to avoid a prostaglandin. Prostaglandins are known to exacerbate inflammation. They don't cause it, but they will make underlying inflammations worse. What else might you want to avoid, knowing who she has? She has, by the way, she has sarcoid. Her test came back positive for sarcoid. She has a lung disorder. You would avoid a beta blocker, which affects breathing. So that leaves you with a carbonic anhydrase inhibitor or an alpha agonist, like a brimonidine or a Trusopt, basically. I don't know what you all would call it. Carbonic anhydrase inhibitor or alpha agonist. And you just treat, you treat it just like you would a regular glaucoma, but you're restricted by your choice of agents you can use because of her eye condition, because of her systemic condition. Are we cool? Y'all did good. Any questions? Yes, sir.
Steroid is normal, ongoing. Sorry, would you be able to reduce the steroid, do you think, on this one, that it would?
Well, yes, by tapering the steroid, that alone might bring and that's what you're thinking, right? Let's just get her down from every 2 hours to twice a day, and her pressure might come down. Absolutely. And I would do that, if the cup-to-disc ratio was not 0.8 by 0.8, I would do that. Even if it was 0.5 by 0.5, I'd say, you know what, 31 is really not that high. A steroid responder is 50, 40. This is not that high, but in the presence of a 0.8 by 0.8 cup-to-disc ratio, you should treat. If the cup-to-disc ratio wasn't so threatening, I would say, well, let's just leave 31 alone and try to taper the steroid and see what happens to the pressure. And I bet it comes down.
Yeah, can you tell me your rationale for injecting? When would you start injecting? And also, from the point of synechiae, when would you think about a sort of a midricaine for synechiae, also injecting?
I would not inject just on the basis of synechia. I'm pretty confident I can break synechia if I use enough steroid drops and enough red top drops. Okay, but my threshold for injections are a lot higher than they used to be. When I was younger, I was a little more cavalier, and would put needles in the eye whenever I had a chance. There's some inherent dangers with that, y'all. So if, like the second case I showed you, where she just wasn't getting better, it wasn't getting gone. If it doesn't resolve, I use a needle, put it that way. This one, she resolved finally. She got better. So I reserve needles for when they're just not getting better. And I'm not saying not improving. They might improve, but they don't resolve. Right?
I suppose just a general kind of question. So you have someone who comes in with, because of their eye. So an eye problem brings them in, and you think that they've got a systemic problem, which is causing that. So I tend to differentiate between just an eye problem, where it's purely eye, happy treating that, and a systemic problem that happens to have an ocular manifestation, which has brought them to you. Personally, from my point of view, I'm happy to diagnose, but because they have a systemic problem, at what point do you then go, you know what, I'm an eye doc, now you need to go off to see the physician. Right. When do you tend to hand over?
So in the States, I hand over, I would hand over all these people, but I wouldn't hand over them saying they have a granulomatous uveitis, figure out why. I figured out why. So I do the blood work to figure out the why on the eye. The why. I'm not going to treat these patients for tuberculosis, and I'm not going to treat them for sarcoidosis. But I want to tell the internist, this person has sarcoidosis, because they might screw it up otherwise. Seriously, that's the way I look at it. So I don't just say, oh, they've got a granulomatous uveitis, can you figure out the why? I can figure out the why better than they can, but I don't want to treat it, and I can't treat it in the U.S. So I do a little bit more work, but other people will say to them, there's nothing wrong with this. Person has a granulomatous uveitis. These are the conditions that might cause it. I'm going to send you to the internist to try to figure that out. That's fine too. Whatever comfort level. I just happen to feel that the more information I can provide to the internist, the more successful the treatment will be, and the less likely are to screw it up. That's just me. But I don't treat them either. Look, I'm an eye doctor. We cool? Thank you so much, y'all.